A very good afternoon to the August gathering here. And this is for the first time that we are having this session, which is called the debate on the cruise. And this great concept was conceptualized by our chairman scientific committee, Dr. Partha. He said the land is no longer available, so why not encroach the waters? So we then took hold of the cruise to have more sessions. And there came the 6 sessions, which became a very hot wanted sessions. So this is on cataract, and I'm really thankful to the August gathering here. And to chair, I will welcome Dr. SPS Grewal. And sir is a high volume cataract, and everybody knows it that he has been one of the high volume cataract surgeons, a great teacher, and great innovator. Co-chair is Dr. A.K. Grover, sir, and he's very, very close to the Indian ophthalmology president, ex-president, great teacher, and I think he has been a great mentor to all of us. Welcome, and thank you. Welcome, sir. So to moderate with me, I'll welcome Dr. Arun Kshetrapal, and again from Ajmer. Panel we have Dr. G.S. Dhami, sir, Dr. Vinod Arora, sir, Dr. Shikha Basi, Dr. Praveen Sen, Dr. Sanjay Chaudhary. I think he has left because he had a award-winning session. So without wasting and without taking much of time, and as the cruise, I think, can we go for the cruise? Kahan gaye, Captain? Somebody joining? So this is a 90-minute cruise. 90? 1 hour.
90 minutes.
So introduce the first session, no?
Yeah. So the first session will be a debate between SICS, FICO, and
Sudhi?
Flax. So we have evolved from ECC coming down to SICS and then to FICO, and now we are doing laser-assisted cataract surgeries. So let's get on with our first debate. Our first speaker is Dr. Sudhir Singh. He's a prolific small incision surgeon, not only a small incision surgeon, but he does a lot of phaco's also, and he's a very nice phaco surgeon also. So Sudhir, we'd like you to put your points in favor of SICS. Thank you very much.
Good afternoon and welcome to the cruise. So all we know, all cataract cannot be conquered with the phaco. This is undebatable. So we need something extra. So what are the options? Phaco flex and phaco SICS. So phaco flex is a fatal combination for surgeon as well as for the patients. And phaco and small incision cataract is a perfect combination for both. So femtolaser assisted surgery, even all cataract cannot be conquered. Manual small incision surgeon, all type of cataract can be done. So yeah. So MICS cataract surgery is now refractive surgery also. Pre-existing astigmatism can be neutralized by simply placing your incisions or customizing your incisions. So no need of toric IOLs. So this is a nomogram published in the cataract refractive surgery. So you can have according to your surgeon's SIA induced normograms. So MICN multifocal vision by monofocal IOLs. Now I am just asking, questioning the multifocal ring IOLs since the 2002 that these rings are not good for the vision. So now we have come up with like enhanced this EDOF and all that. So simple idea is you create the astigmatism, and these are different combinations and permutations. And this is paper published in AIOC in conference also. So you can have perfectly different. Your patient can be non-dependent of glasses. So what is it? This is we found that minus 0.75 diopter residual myope. So again, I would like to say you give your patient ring-free, sconda-free vision, and these are the basic principle for giving the multifocal vision by monofocal pseudopic eye. So why I love cataract refractive surgery is scientific, safe, economic. So I am showing the small PTO. This is a posterior polar cataract, and people are investing like 4 crore, 5 crore flex for this. And flex doesn't mean any safety to this. I'm saying with all scientific work, because flex can't do the horizontal dissection. So few tricks can save you. Even also, phaco is like pressurized chamber surgery. If there is rent, then your nucleus is going direct to the retina. But in SICS, there are no chance, particularly if you are doing safely. So in this, your rexis would be 4 or 5 millimeter. If there is a rent, you can put a good PMMA lens. And after, if your incision planned accordingly, then you can do. So this is nucleus is just separated out from the epinucleus, and this, when you conquer this, either you conquer with phaco or something else. So this is simple nucleus management. So taken out with the vectis. Now one of my innovative technique comes here. I do hydro expression and visco expression of the plaque. So this is hydro expression. Just I am taking out the epinucleus plate and just disillusion out and still attached to the posterior capsule. Now we are doing this is visco dissection. So this is again controlled step, pressing the posterior lip of sclera. And here we go. This is done beautifully. Now you can plant any lens, or you can do this with a yeah. Even if there is any rent, that can be managed, and there is not much cortical matter is remaining. So as I would say, just in your armatorium, you learn this simple technique. Okay, simple technique. It's good for all, because patient safety is paramount of importance than our ego. Machines cannot do every work. It's surgeon who can do many things without machines. So keep your life EMI free, bundle free, tensile free, because you have one life only. So don't earn for the companies. You learn techniques, and that's all. Thank you very much.
Thank you, Sanjeev. I'll call upon Dr. Anurag Mishra to give his point of view, and we'll discuss in the end of all the three debates. Requesting all of the speakers to stick to the time, as we are in a tight schedule.
All right. Thank you for the opportunity. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. Before we go to the debate proper, let me give you an exordium to the debate. What are we disagreeing upon? We're trying to compare a patriarchal primitiveness with a science-modified being who, God knows what he still preserves his primitiveness, with something that's decent, with something that appears a suit all and appears like a proper human being. Science had the first invention of the human civilization was this, the wheel. Okay, science modified it many ways to reduce the friction, but science overdid it in certain cases to bring the friction down to zero, because this will no longer roll. It will stay, so there's no friction, right? These are the steps of cataract surgery. I'll not focus more on them, just 3 steps, because these 3 are the steps that are crucial. And I will not quote any literature here. I'll just show you what I do with all these 3 procedures, right? Coming to the incision first. The incision with SICS, there's nothing wrong with it, but there's a lot of preamble. Before you go into the proper incision making, there's a lot of things that you need to do before you actually enter the anterior chamber. With a phaco, the incision already made, but the surgeon still does a lot of preamble before he finally gets access to the anterior chamber. With the phaco, nothing. You just stabilize the globe and enter in a jiffy. So the resection is made. You can judge for yourself which one of them was the easiest. The incision in flax is also more difficult when the eye is moving. The incision in phaco is not at all difficult when the eye is moving. You always have the fixation thing. With a solid dog, it's even more difficult. CCC in SICS, nothing wrong with that. Again, you're opening the capsule, fine. But the dimension of that capsule opening is so large that even a whale can enter and come back in. So this is one guy who does not feel like entering the door in a short doorway. He wants to open it, blast open it before he tries to enter. CCC in flax, it's a modified can opener technique wherein you have the laser dots. They're very closely aligned, all right, but still it's not a continuous line, it's not a tear. CCC in flax, this machine does not know where to create it, so it has to be shown a direction where exactly you want it to puncture the anterior capsule. In phaco, there's nothing. You go in, you know where it is to be constructed, you can still do a reasonable job with regards to its orientation, geometry, and location. Nucleus management in SICS, well, this is management you call. This is out of the bag delivery, delivering it out, and propelling it out of the incision site. So the last time I checked over the various English dictionaries, extrusion and management meant different to me. But they are probably the same when it comes to SICS. Nucleus management in phaco vis-a-vis flax. This is on the left-hand side, you have a flax, equal grade of cataract, very hard.
1 minute.
This is after flax, and at the end of the day, you talk about CD. I'm sure the next speaker is going to talk about or highlight the CDE count. When the time comes, you will see that the phaco with an equal hardness of cataract does manage it faster. You're already into the pi management there, but we're still struggling to separate the pieces, despite of the fact that it has been pre-fragmented with a flax machine. So the CD count, as you can see, they rise. It's 10.10, it's 10, so it's comparable either, or it is more on the flax side. You're almost finished the job. This is an unedited video. We're still struggling on the other side. The closure in SICS, it looks beautiful. It looks like a phaco, I agree. But the fact of the matter is it does not behave like a phaco. That's where the management is. Financial implications, I saw the previous speaker. Tell me, ladies and gentlemen, how many of you caught that to reach Kochi? And how many of you did catch this for Kochi? However, it is your choice whether you want this comfort in the plane or not. That is BC and economy class. I'll just finish it top. Ladies and gentlemen, whenever a surgeon is happy, they say, there's always a phaco machine in the background. Whenever a surgeon is happy, they say, there's always a phaco machine in the background. So red and blue are just corners. The winner always takes center stage. Herein with this, I rest my case and open it to your judgment. Thank you.
Wonderful talk, Amit. Wonderful. Calling upon Somil, he'll be talking about his points in favor of flax.
That business class luxury, Anurag, you only can afford.
That's your choice. You fly.
You fly economy, you fly.
That's a business class.
No, let the conveners and chairman decide on that.
Sir, you have the chair and co-chair sitting.
Honor there.
Lovely. Thank you. And we are here on this wonderful cruise in Cochin. And I'm here to tell you why femto is totally worth it. All right? As opposed to what my previous two speakers have said. Let me start by saying sometimes the issue is simply that the ceiling is your floor. That doesn't mean that you're staying above them. I'll tell you what it means. Now, the evolution of cataract surgery through the ages, we know that it's right from couching to the ECC, the IOLs, the phaco, and now the flax. And throughout history, there have been pioneers who have changed the status quo, right? These are all brilliant scientists, physicians who have changed what they did. Now, it is said that if you're not upsetting anyone, you're not changing the status quo. So let me take some examples. Jacques Daviel, who invented the ECC, He upset the environment. Sir Percival Potts said, and severely criticized the surgery, the ECC surgery, dismissing it as mere fashion. Sir Harold Ridley invented the lens. And of course, none other than Sir Stuart Duke Elder threatened to debar doctors who were practicing IOL implantation at that stage. Charles Kilman, of course, phacoemulsification. And there was a huge hue and cry in the crowd saying, phaco ko phaco. Ultimately, it's here to stay, right? And history repeats itself. We are having the same debate right now as well. Of course, SIC is not in the debate anymore, sorry. But so why femto? Why not phaco? And definitely why not SICS? I'll tell you. The difference between ordinary and extraordinary is that little extra. You have to go the last mile. So let's talk about the same things which my previous speaker said. Incisions. We did a study at Bombay City Eye Institute, and we studied the uniplanar versus biplanar incisions. Although both are good, biplanar is definitely better. And LensX created 100% biplanar incisions, the way we wanted. Also, this is an anterior segment OCT study. Local desmus detachment, more in the keratome, less in the LensX, which reduced further the next day. What about arcuate incisions? For our low astigmatic patients, without having a toric IOL implanted, we can treat up to 0.5, 0.25, maybe 0.75 if you're okay with it, without the toric lens, which you cannot be at that sure and that reproducible without the femto. Let's talk about capsulotomy, right? Laser capsulotomy, superb. Here you can see the manual rexes. We cannot reproduce it 100% level to the precision which the femto will do it for us. It's the femto, the machine is doing a lot of steps for us. Of course, the hand behind the machine is always there. You have to guide it, as he said, but it's doing the things for us. It's making things simpler. Look at the difference between manual and laser capsulotomies. It's beautiful. Better capsulotomy, more regular, leads to a better lens position and better calculation of ELP, and hence better results post-operatively. Remind you. Let's talk about nuclear management now. Here you can see just one of the cases which we have done. And you can see that it's unlike what my previous friend and speaker said. You can see that it's already pre-divided. You hardly have to do anything. Look at that. I'm just separating them. I hardly need any lateral motion also. So the thing is, it makes our job very, very simple in all situations. Not only about, I'm talking about hard cataract or soft cataract. In all situations, it really makes our job simpler. And when we have our job simpler, we can do a better job for our patient. We can make a better outcome for our patients. Of course, as you said, the energy reduced is substantial. It's not something like a minuscule. We are talking about an average reduction of energy by around 43.69, 44%, mind you, right? So, but what about the studies, right? So now technology has evolved.
Please conclude.
Yes, I'll be concluding soon. So it has evolved since the publication of these studies. Most of them are outdated, and many include the learning curve. And of course, the technology has improved, leading to lesser complications. Meta-analysis shows distinct favor of flax in terms of EPT and postoperative corneal thickness, and they overlook the ease of flax. Also, by my esteemed colleague Shell and his group, they had said that the flax showed they showed favor in the hands of junior surgeons, right? So it helps, is a huge help for inexperienced surgeons, and it adds perfection and safety in more experienced hands. Of course, some cases are more favorable, suitable for flax than others. But what about the cost? Well, there's a saying say, live rich, die poor. Never make the mistake of doing it the other way around. Always in our lifetime, spend for the betterment of our patients, spend for the betterment of the outcomes so that your reputation increases in their eyes. My job was not to make things easy on people. My job is to make them better, make the job better. The quality of a leader is reflected in the standards they set for themselves. The standards should be very high. And that's what I meant by saying sometimes the issue is that the ceiling is your floor. Your standards are so high that there's other people's ceiling is your floor. So let me conclude by saying, first they ignore you, then they laugh at you, then they fight you. That's where the stage we are at, and then you win. Thank you very much.
So let me update or educate my esteemed colleagues. SICS can be done from 4 millimeter and one thing more. Still, we are working with our foots We are not using any machine. Okay, so that evaluation is not good for everything. Yeah. Again. In femto also doesn't increase accuracy, doesn't prevent the endophthalmitis, and you are saying that incision and all that. So if you see the review of literature, it's full of complications, and there is a one paper of sir in the American Academy of Ophthalmology, complications of femto laser, how to manage them. So it's not complication free. Thank you very much.
So let me introduce Dr. Sudhir Singh. He is a great fighter from our state, Rajasthan, and he has been a great debater in all our conferences. So just be, very positive for his spirits.
Lovely for anybody else who wants.
Any 60 seconds for any, hey, Anurag, Somil,
Yes, of
do you want to
course.
defend your...
You want to defend your case?
30 seconds.
30 seconds.
Let it go.
You can try your muscles.
Be gracious.
And now fight with yours.
Not together.
No, why would I?
I agree that the fight is ours because SICS was never in the picture anyways. Yes.
Okay. You fight for a second, please.
But stay away from each other. No one.
I will not. Why would a winner see? Australia will never defend its world. They are already the champions. Why would I defend anything? I've already made my point, and I'm sure I've reached out to the audience. Let's see a show of hands.
Not
That-
yet. No. 30 seconds for that.
Anurag with his all eloquent words, and he's like Shashi Tharoor, right? Don't you think?
Okay, let's now. Time is over. Say that. Now the show of hands. Who votes in favor of SICS?
Show of hands. Who made the most compelling argument? Not about their personal choice.
Based.
Compelling, you would have swayed the audience. That's how you gauge it.
So what's the take home from all these three, speakers? So SICS? So...
1, 2, 3, 4.
you could persuade three.
Okay, and for FECO. Okay, and for FEMTO. Minority. So all three. 1.
So, sir, Anurag has to return his femto.
Absolutely.
Somil has to return his paper machine.
Back to moderators.
Next.
Sir.
Thank you.
Very nice, thank you.
Okay. Next debate is between scleral. Between the trifocals and the EDOFs. So before we begin the debate, so how many of us are in favor of EDOF right now? And how many of us are in favor of trifocals? Okay. So the debate is not basically EDOF versus trifocal, when EDOF and when trifocal, right? Somewhat that. Debaters, Dr. Sataj, please. Can you introduce?
So Dr. Sartaj from Grewal Eye Institute is a high volume press biopic user, lens correcting user, and he's a high volume phaco and refractive surgeon, and he is speaking for trifocals. All to you, Sartaj.
Thank you so much. And I must really say, wonderful idea for the debate on the cruise. It's very well put together.
Once they fight, they can't even jump off.
Yeah. But you can push the other person off. That's okay. I'll just use this. So, as was very correctly pointed out, that the question over here is not really which technology is better, but which IOL is better. And the premise of this whole debate was that our chairman's scientific committee needs to undergo cataract surgery. So, what lens are we choosing for him, trifocal or EDOF? So, I am only going to talk about that. I'm not really going to go into the technology of the lenses or anything. And I will start by saying trifocals are really the only choice as far as our chairman is concerned. I'll just give a very brief overview that this very recently published article said that when you compared depth EDOF lenses versus trifocal lenses, trifocal lenses provide better near vision. In fact, I'll say only trifocal lenses will provide near vision. EDOF lenses will not. The analysis also actually said that as far as other photic phenomena are concerned, it was more or less the same. So we should match the IOL with the visual needs of our patient. So what are the visual needs of our chairman scientific committee? It's quite simple. He needs to read a lot. If we look at AIOS this year, there are 130 instruction courses, 321 free papers, 58 young master courses, 950 e-posters, nearly 300 videos. That's a lot of reading. And I don't want him to see a bloody booklet like this. I want him to be able to see it very clearly, and that too without glasses. So if you look at it, 2,500 abstracts in total. Even if that's a 50% acceptance rate, that goes to almost 5,000 abstracts. That's 166 hours spent just reading. Do we really want him to be sitting there with glasses all the time? He needs to read so much, he has to read it wherever he can. Always putting glasses on off is not the way to go. Not only that, but beyond just the reading the abstracts, we all have these menaces that we have to deal with. Again, we'll always be looking for glasses when we want to reply to our friends, when we want to reply to queries by different people. And someone pointed out Shashi Tharoor. I think the real Shashi Tharoor is our chairman scientific committee. There is no one quite as eloquent as him. And someone like that has to be an avid reader. Again, why not give him that gift of eternal youth to be able to read without glasses wherever you want, whenever you want? And EDOPs will not do that. Only and only trifocal IOLs will do that. So anybody who is so dependent on near vision, who's so dependent on reading, trifocals are the way to go, not EDOF lenses. And someone as learned as our scientific chairman committee member, chairman of the scientific committee, understands neuroadaptation. He understands that it'll take a little while. He will get much more comfortable with this. So even the chair time with him in the post-operative period should be quite limited. I rest my case. Thank you.
That was a nice presentation, Sartaj. But you forgot that the chairman scientific committee is an avid driver also. He drives, he loves driving, and he maintains 2 Ferraris as well. So I'm just giving clues to Shell. So Shell, EDOF, all to you.
So I think everyone wants one perfect lens which they can blindly select and they want to blindly put without thinking too much. And I think the number one reason why all of us have so many sessions on which personality to choose, angle, alpha angle, kappa, corneal aberrations, this, that, etc., is that all of us are worried of that one patient who comes every week, every 2 days, takes up half an hour from your busy OPD, and you just keep giving chair time after chair time after chair time. So the number one reason surgeons hesitate to implant multifocal IOLs are dysphotopsias and quality of vision related issues. With increasing life expectancy and increasing period of active life, anyone and everyone from rural to urban areas now have access to phones and screens all over, and therefore need for good quality vision across different ranges is important. And not all patients are unfortunately suitable for trifocal IOLs, but believe me, all patients want to do everything as much as possible without glasses, and that's unfortunately a reality of life. So the major advantage of an extended depth of focus lens is no dysphotopsia. The minor disadvantage is that they may need some reading glasses. But if you look at your general OPD and patients coming in their 40s, when you diagnose them presbyopia for the first time with 0.5, 0.75, 0.1 diopter, and you tell them to get glasses weight, they'll say, is it okay if I don't wear? I'm still able to manage with changing my reading distance. So if they can manage for so many years before putting on presbyopic glasses, I'm sure the pseudophakic patients will equally be more adjusting. And I'll go through some cases to do that. A senior manager in a factory, Ahmedabad has a lot of industries in the peripheral areas. He's a myope, and he drives back on his own on country roads, single roads, no dividers, no street lights. And he's had to start carpooling with his colleagues because he can't drive back home at night.
So as glare and night driving is his primary concern, obviously trifocals go out of the window. So we decided that we'll go ahead with a bilateral EDOF IOL, and we told him that you'll probably need some glasses for reading. And he's excellent for distance, intermediate, and reasonably very good for his functional near vision. And he tells us that he's able to drive comfortably. He's able to read his newspaper by enlarging the font on his phone. And he uses glasses very selectively when he's checking his bills and accounts at the factory. And the best part is that there are no internal aberrations, as you can see, even with those modifications that are there in the central part of the area of the lens. Now, this is a 64-year-old lady. Husband is suffering from chronic ailments, very well to do, but children are settled abroad. So she's taking care of the husband, running the house, and she's also doing a lot of stock markets herself. Hypermetropia with presbyopia, keen on spectacle independence, but she doesn't want any compromise in the vision because she's the main one running the house and taking care of her husband. So we said, let's try one eye. Let's see how you respond with one eye, how your intermediate and near vision is. And maybe in the other eye, we may consider a slight myopic offset. So after the first eye, she was quite good for intermediate and near. And in the second eye, normally I would have chosen a 22 diopter. So we talked to her and we chose a 22.5. So we went for a slight myopic offset in the second eye. Following which she's extremely comfortable for near as well as the intermediate. And the only time she uses reading glasses are checking expiry dates on her husband's medicine. And I think all of us will agree medicines reading charts on them are impossible even in emetropic eyes. And there are now articles to suggest that doing a slight myopic offset of up to minus 0.5 diopters does help to improve the near vision. Talking about scientific chairman committee, here's an ophthalmologist. Unilateral cataract, drives to a peripheral center once a month to operate. He knows he has a clear lens in the other eye and is hypermetropic. His otherwise eye is suitable. He's doesn't do too many EDOFs in his own practice, and he was hesitant, and he was considering and toying the idea of an EDOF because his colleagues were suggesting him. But being a unilateral cataract, he was very concerned whether I'll be able to operate well or not. After a lot of discussion, we went ahead with Flax and Vivity, and he's able to operate without any difficulty, no problems when he drives on his own. And when he's at home, he hardly ever uses glasses even for near vision. Compromised eyes, 73-year-old gentleman with fine ERM. How are we going to give him a trifocal IOL? There's no way you're going to give him. If you're going to give him, that's not something to be done. So we explained that it's not possible to give you a trifocal IOL, and therefore we went ahead with an EDOF, and he's doing quite well. And it is a very good, decent vision for near. Uses a small ad for fine print. Another similar lady, she stays in Canada most of the time, just comes 2 months a year to her daughter. Dry ARMD, no fluid, has been on follow-up for more than 7 or 8 years with dry ARMD and cataract, and uses iPad most of the time. We explained to her that you may need glasses for reading and you may need extra light because some contrast may drop. But she calls us every time when she comes back here that she's now never used glasses to use her iPad when she's in Canada, and her contrast is also equivalent with and without glare like a monofocal IOL. And the final case of a radial keratotomy done in the past, but a regular cornea in the central pupillary area of the mesopic pupil of the eye. Obviously, you're not going to choose a trifocal for this because you're not sure how your biometry is going to hit. And how the quality of vision may be affected. And this patient did very well after an EDOF IOL. So I think EDOF IOLs are definitely to be considered in, you can consider in even moderate early or moderate comorbid eyes. They deliver excellent quality of vision compatible with precision-oriented individuals, including surgeons, active surgeons, compatible in a unilateral cataract. They have surprisingly good functional near vision. And with some amount of mini mono vision in appropriate cases, you may be able to make them relatively spectacle independent in their routine life. So I think EDOFs are one category of IOLs which you can blindly choose for everyone, I would say. Thank you.
Thanks, Shell, for putting up your point so nicely. So can I have Dr. Grewal and Dr. Grover to please comment?
Where's the other speaker? Okay. So, okay.
Can we have the trifocal
Your patients, some of your patients are very demanding. They would like to see the newspaper. They would want, Partha wants to read his newspaper in the usual light. He doesn't want to go under the sunlight to read. So how do you help him with your job?
The way I'll help him is I'll tell him that with age, why did you develop cataract? Because you aged. So your retina also ages, and with aging retina, you need extra light. That's normal. So use extra light and get your.
Can I help you out here? The same demanding patient can be very, very messy if he has rings and halos.
No, it is
You want to drive car, then the reading.
it is much simpler. Give him a pair of reading glasses.
1751 down.
And don't tell him
Anything that doesn't work out well, your retina is weak. That's the safest answer.
you tell anything but saying that you are aged now.
That's a fair question. But I like glasses. Honestly, even if I had 0.25, I'd probably still lose.
No, Sartaj's wife likes him in glasses.
So now, how many are you going back and using EDOF in your patients? So let's see how many. Oh, great hands. So, hey, Shell, what did you do, yaar? And how many of you are going to practice trifocal as the regular? Hey, the hands dropped, yaar. Hey, what's that? So that was very discouraging for the industry, yaar. The trifocal hands almost went down by 50%. So you want to be thrown off the cruise?
You give the option of using both. Technologies coming in EDOF are going to be mind-boggling.
So I think both of them were very justified in putting, and I think the way Partha is demanding, I think he's right. He would require a trifocal because he's a very avid reader, but at the same time he drives his limousines and Mercs. So I think you had made a point. So both of you did a great job. Can we have some encouragement? Yes. So very yeah.
No, for the masses, if you ask, if the debate was about one IOL for the masses, then I think he's.
I think ask a question: which lens would you want for yourself? Monofocal or EDOF? Monofocal. I was sending two of my first cousins and my bhabhi last month.
No, it can.
The trifocal have limited choice.
No, it can be very subjective.
I can ask one question with your
The question is for the masses, which IOL?
See, the bottom line
I
is when
can,
you
with
go from a
permission of-
trifocal to an EDOF, it is that you have already told the patient, I'm sorry, I'll not be able to give you what you want. Instead, let's go for this. So
No, it's not. What I'm saying is trifocal. The message should be trifocal is for the niche people.
I think fair enough, but I think also in today's day and age with these new monofocal IOLs and EDOF, it's now either trifocal or EDOF.
I think for trifocal, it's essential there should be no morbidity.
Yeah.
That's the
Without a
first
doubt.
point.
Without a doubt.
And
No,
most of our patients have some problem or
I
some
think
other.
more than morbidity, you have to look at the personality. Of the patient
Personality. I
also.
think
you have to have chair
so.
time.
You have to
Yeah.
choose the right one for the right person. That's the answer, and you need a judicious combination of the two.
And King Solomon spoke.
Give ruling.
Okay, next one now.
So I think that combination to me sounds very weird. Although a lot of people must have tried, but that combination, it's not justified. One technology, because they both are of a different technology.
Usually happens that you put a trifocal, somebody has put a trifocal and you realize he has a CMV and there's a problem with the retina, then you end up putting a.
So that's a different, the more.
It's kind of a compromise.
Okay, let's go
So
move on.
now
Let's
we move to the debate 3, and it's basically intraoperative small pupil management. And see, look, Harshul has really, thrown his debaters off the board, huh? So, but still, we could manage someone for you. So we'll have Harshul talking on Malugins. So we have 3 debates here: capsular hook vis-a-vis BHACs and vis-a-vis Malugins. So Harshul will be talking in favor of Malugans. And we have Dr. Rajesh Joshi, so very kindly consented to talk in favor of iris hooks. And he'll be talking an extempore. No, you continue. Yeah.
No, let him go for iris hooks.
No, he'll debate out you. He'll debate you out. He doesn't have any presentation.
Okay. So afraid were the hooks and the legs.
इसको एक बार ओपन करके व्यू तो देखें तब तक.
Okay.
So we can have a view outside. Maybe Harshul, give us a minute, yeah. Can we just pull that off also?
स्लाइड दिखे नहीं दिखे.
सबसे पीछे की है ना विंडो, वो रिफ्लेक्शन दे रही है. That one.
अरे यार डिबेट में सुनना ही तो है.
स्लाइड दिखे ना दिखे, ये देखना चाहिए.
ये क्रूज का फीलर. हाँ? अच्छा हवा आ गई.
Is it visible here? Okay.
Any of the curtains to be pulled down?
No, it's better this way.
So that's called mix and match technology.
So thank you so much, and good afternoon, everybody. So as you can see that people who believes in iris hooks and B-Hex ring, they're not boarded this cruise. Why? Because they know that Mulligan ring is the clear winner. And in fact, I think Dr. Mulligan, with his invention of this Mulligan ring, why I call it magical is it has made our life very simple. In our PG days, the biggest problem of any phacosurgeon was a small pupil, people who are on pilocarpine, who are not dilating. There used to be a mess when we are doing surgery. But with the invention of this device, it has made our life very easy. And let's see what are the advantages while this video is playing. So we all know that to put iris hooks, we need extra incisions. We need extra 4 or 5 incisions to put iris hooks. And most of the people, they do it with peribulbar block because there are extra incisions to be placed. And once you place iris hooks, they are not at the same plane of the iris. So when you hook the iris pupillary margins, it tends up. So there is anterior chamber is not deep enough, and there is a lot of problem when you are doing all the manipulation in the intraoperatively. So whereas in the Mulligan ring, you don't need to make any extra incisions. You can do this surgery under topical anesthesia in most of the cases. And you just need to take out the ring from the same incision which you are using for phaco. So you don't need extra incisions there. And this ring, it comes with this injector. So here there's a case which had undergone penetrating keratoplasty. So you just go ahead and there's a small pupil there. You just go and put some viscoelastic beneath the pupillary margin. And this made of 50 polypropylene, the original version. And the newer version is also there, which goes through 2 mm incision, which is made of 60 polypropylene. So it has 4 scrolls. And these scrolls, as you can see, the leading scroll is engaging pupillary margin. And the same time, the lateral scrolls, they engage the lateral margins there. And this is a case in which peripheral iodectomy was done. So you need to use little bimanual technique to push and pull. You push the pupillary margin toward incision. So once this ring is in place, it lies at the pupillary plane. So it makes an opening of 6.25 millimeter, and it remains throughout the surgery. Many times you don't feel a thing that this device is there in the eye. It basically gives a 8-point fixation. These 4 scrolls, it makes a perfect round pupil. So you don't feel a thing. Whereas if you use iris hooks, it gives a shape of rhomboid, or it makes a square shape. If you use BX ring, that's also a pentagon kind of thing. Then opening is also not large enough. And moreover, if you look at the profile of the BX ring, it's very thin profile. It can't hold the pupillary margin very strongly there. So it's very easy to use. And believe me, once you start using this ring, you're not going to go back to any other device. And it's very easy to explant this ring also. So once you do the surgery, another advantage is you get the perfect size. You can really size your capsulorhexis to the perfect sizing. You can push this ring to one side and see where your margin is, and you can make a perfect capsulorhexis, which is very essential for the type of the IOL we are using, these aspheric IOLs, multifocal IOLs, trifocal IOLs. You just need to disengage all the scrolls with a Kuglens hook, and once you have disengaged all the scrolls, either you can use the injector or you can just use the Kuglens hook, invert it, and this ring comes out easily. So it's very easy to use. So this was the Maligan ring, which was, I showed you the advantages. And I think Dr. Rajesh can give some views about iris hooks. Thank you.
Let's hear Dr. Rajesh. Come.
Let me have my video if it is possible.
Yeah.
Dr. Rajesh Joshi.
I am without my weapon.
Files.
So I think that
Files.
You want me to show a video of iris hooks? I have. I can play that. You can. No, but how will you play?
नहीं अभी को हम फाइल्स ये देखो कॉमरेडरी ऐसी कि दो को पहले पानी में फेंक आया है
Accept.
So, just a quick word from all of you. How many of you are using the B-Hacks, our own indigenous Suvins ring? Okay. So, and Malugans and iris hooks. Oh, that's a huge number. So I think iris hooks, okay.
Harshal, in the meanwhile, Harshal,
Sir,
a pupil like this, Kamal,
And there are people,
in a case like this, why would you just stretch? This would stretch very well if you use true Krugler's hooks.
So I think we have stopped stretching the pupils anymore, sir. It causes more inflammation, releases more inflammatory mediators, and you can never maintain that dilatation. The problem is iris become more floppy. You can't maintain that dilatation. So everything, all your procedures become cumbersome. They become, there are chances of complications. Yeah.
Yeah, true.
Yes.
Can I add one? There are two type of people. One is fibrotic, and if fibrotic, you can't manage with the rings. And other
I'll show you fibrotic. So whatever is you need, you can do with this ring. Believe me.
No, not.
Believe me, it makes your life so simple.
No. Fibrotic people, you can't. Your pupil was not fibrotic. That was simple pupil.
I'll show you the case.
No. But I have so many cases. Okay, so that.
Dr. Rajesh, can we have just an extempore?
Okay, rest after
okay,
his
so
presentation.
now we have
You
Dr.
have to see it to believe it.
Next after his presentation.
So we
Yes.
have,
You said that the hooks you need a block. You don't need.
I know. We also do put iris hooks without block, but majority they love to block whenever they are using iris
Okay,
hooks.
after this. No discussion now. Yeah.
yeah, thanks for the opportunity. In fact, my weapon is not working, but you can see the type of the pupil. Okay, very small, and yeah, just imagine.
Actually, what he's proving is that pupil is so small. What he's saying is pupil is so small you can't even see.
You cannot see it, and you won't be able to put Maligan ring in this patient. Okay, and apart from that, this patient had a chronic uveitis. He was one-eyed patient, 80 years old. We are following him since long in our medical college. Okay, medical college. But yeah, so we took this patient for cataract surgery with all consent and everything, because you never know what is there inside. Once you open the window, what is going
Closer
on
to
there,
the
we
mic.
don't know. We don't know. So We went ahead with surgery under topical anesthesia without any block with lignocaine jelly, which was instilled 15 minutes before the surgery after paracaine drops. After creating an incision, main incision and a side port, we instilled tryptophan blue. And then we tried to break down the synechia in this patient after putting viscoelastic. So it wasn't very easy to break those synechias. Few synechias we could break, but the pupil was small, and we thought that even if we go further with the surgery, it's going to become small. So we took 4 incisions at the 4 corner diagonally opposite and put iris hooks. And after putting the iris hook, it becomes very easy performing the capsulorhexis and the going ahead with the procedure whatever possible. So this patient was doing this patient is doing very nicely. He had a center IOL and there is no post-op reaction anything. Now as far as Maliguin ring is concerned, I'm not sure how many people may not be able to do surgery in the cataract which Harshul has shown. I think without dilating the pupil or without putting any ring or using any sort of expanders, we will be able to do that surgery, I suppose. And it is a cheaper one. Iris hooks are cheaper one. We can use it many times. We don't need any instrument to implant the iris hook, implant the Maliguin ring, as well as we don't need any instrument to pull it out also. Maybe routine instruments which we are using for cataract surgery, they may be useful to put iris hooks and remove them. So I think looking at the cost, looking at the instruments which are needed, and particularly we are practicing, most of us are practicing in maybe urban or rural urban areas. So this is a cheaper option, I suppose. They are always available. Yes. Thank you.
I think very nicely last minute. Thanks, Dr. Joshi, because it was just a last minute fit in for you and you very nicely debated. I think if I want to add a point, for me, one very great indication for iris hooks would be special cases where the chamber is very, very shallow. And so for these small pupils with AC chamber shallow, I don't think you can fit in any ring because then. So all said and done, I think it's a combination of the device which works best in your hands.
No, don't talk about combinations yet. Till you have polarized people and divided people into groups.
I was just trying to support him because he was working without his presentation. So yeah.
Now let's have the votes first. So those in favor of iris hooks as their first preference. You have only to vote in favor of one or the other. Iris hooks, okay. About 35%, okay. And what about the Maliguin ring? 10%.
and B-hex
rings. Sole representative.
So can you have just a minute talking in favor of B-hex? What do you feel special about B-hex vis-a-vis Malugins?
Good afternoon, everybody. Myself, Dr. Anup Shah. I am from Nasik.
Yeah, let's listen.
Yeah.
I have collection of
Yeah, myself, Dr. Anup Shah. I am using BX rings since a long time. They are very easy to use. I have not used Maliguin ring, but BX ring is not very difficult to put and to pull out. It just requires initial few learning curve for a case or two, but after that everything is clear. And as far as cost is concerned, the way you ETO your hooks, the way similarly we ETO the BX ring, there is no harm in No. It doesn't deform. You can use it for 2 to 3 times. That is. So, from my point of view, iris hooks takes little longer time. There are more incisions and more chance of complications like endophthalmitis, where any ring would have only one single incision. So, BX ring to me appears first choice as compared to the iris hooks.
Thank you. Let's have the next one. We have only 25.
There are some refreshments at the back, so you can have a debate whether you want to have a muffin or you want to have a sandwich or a cookie. Oh, you want to listen to the
Or go upstairs.
Yeah.
So I'll just like to have a quick comment from Dr. S.P. Grewal because he has a lot of experience on using and non-using of these rings. So I'm sure that you can still do it from 3 or 3.5 without using any of these pupil expanding devices.
I have a easier way out. All small pupils I send to Sartaj.
So he's okay.
So let's hear from Sartaj.
Honestly, I have used iris hooks, but now most of the times I should be able to manage it. So most of the times I'll not be.
So actually,
I inject intracameral lidocaine with adrenaline. I put the viscoat to stretch and dilate the pupil. And if it goes to 3.5 or 4, that's good enough. Then you just work within the center.
So I think for me, the Kuglin works best because you keep on retracting and then do the rexes, and then you can, through any hole, you can take out the camera.
Yeah, I think microswing.
So I was going to ask the same question to Kamal. Kamal, you are a very versatile surgeon, I know, and you can take out phaco through a very small pupil, take out the lens. So what's your minimum pupil size when you think that I need some assistant to dilate the pupil? Okay. Otherwise, I know he can do through 2.53 millimeter also. Okay, the next is.
Thank you.
Thank you very much.
Thank you.
Yeah.
Thank you all.
Thank you very much. So, how many of you? What is your preferred IOL once there's an absence of posterior capsule? So, would you like to keep the patient aphakic or do a scleral fixated or an iris supported? So, how many for scleral fixated? Show of hands. Okay, very few. How many of you would go in for an iris? Iris fixated. Iris fixation. Yes, and let's have a debate. ACIOL, yes. No. Huh? Yeah. So ACIOL is also an option. The Calmin. No. That is again and that. So can I call upon Dr. Sonal? She will be talking about scleral fixated IOL. 4 minutes.
Good afternoon, everyone. Thank you, AIOC, Dr. Goel sir, for giving me this opportunity and this platform. So my topic for debate is scleral fixated IOLs. In the aphakic patients with insufficient capsular support, we go for secondary IOL implantation. And options we have is the anterior chamber IOLs, iris fixated, which can be fixated anteriorly or posteriorly, and the long time tested technique is the scleral fixated IOLs, which can be done by suture techniques, or it can be done without sutures also. So coming on to the scleral fixated techniques, where the sutures are used, it evolved from the era of 1991 by Lewis et al. He explained the ab interno technique of fixating these IOLs, where the sutures were used. Then came the concept of making Hoffman pockets, and the sutures were knotted and buried inside the Hoffman pockets to prevent the suture-related complications. And then came the four-point technique fixation by Khan et al., which became very popular, and it gives long-term stability to the IOL, and it maintains the position of the IOL very well. Now, the sutureless techniques have become very popular in the past decade. intrascleral fixation IOLs, which was performed by explained by Dr. Agarwal et al. In 2008, and where the scleral flaps and the conjunctival peritomies, they were covered and with the glues, and hence the name given was the glued IOL. Then further modifications were done by Dr. Gabor Chariot in 2010, where the haptics were fixated intrasclerally out in technique. And nowadays, the Yamane flanged IOL fixation technique has become very popular. It was introduced in 2017, where no conjunctival peritomies are made, no scleral flaps are needed. The haptics are exteriorized, and the tip of the haptics is cauterized to make a flange, which is inserted inside the conjunctiva, and it is fixated in the scleral tunnels. So this is a very promising technique, which is becoming very popular nowadays. Here's a video showing a 4-point fixation technique where the peritomy is done, scleral flaps are made, and around 2 mm away from the limbus, we mark the point for making a sclerotomy. Here the 2 sclerotomies are made on one side, another 2 on the other side. In the IOL, we use dinoprolene. Nowadays, Gore-Tex sutures are used commonly because of the biodegradation of 9-O-proline sutures. So that is also a very good method. The IOL is inserted inside. It is fixated behind the iris at the level of ciliary sulcus. Knots are tied. The scleral flaps are then sutured using 8-O vicryl sutures, and the conjunctival sutures are also tied. You can use glue also to cover these scleral flaps and oppose these conjunctival flaps. So now I'll show you the scenarios where we can use SF IOL and not the iris fixated IOLs. In cases of severe iris trauma, iridodialysis, iris atrophy, or iris tissue loss, I think we cannot go for iris fixated IOLs. In such cases, SF IOL stands above. Corneal opacities or corneal endothelial cell loss, we can go for SF IOLs. In angle abnormalities, we cannot place any IOL in the angle structures. It can disturb the structures of the angle. In cases of glaucoma, we can go for this technique. Iridodonesis cases, we can go for SF IOLs. And also, if it's a dislocated IOL or a dropped IOL, and it is found to be a 3-piece or a rigid IOL, we can fixate the same IOL intrasclerally with the help of glues or sutureless technique. We don't need to open the eye. We don't need to make any corneoscleral incisions or the tunnels. So this is a very good method of implanting the IOLs. Comparison of scleral fixated with the iris fixated. So the SF IOL position is closely approximates the normal anatomical position that is within the bag IOL implantation. So I think this is the main position of the IOL matters here. It also gives long-term stability. Studies have shown up to 15 years of stability of scleral fixated IOLs using the sutures. For iris fixated, we need intact iris structures. There's always a low-grade inflammation or iris tissue inflammation going on. Pupil ovalization, dilatation is restricted, iris chaffing, iris atrophy. There could be IOL-related problems also like decentration, tilt, or drop. Other adverse events like corneal endothelial cell decompensation, hyphema, uveitis, pupillary block, angle closure, cystoid macular edema, and glaucoma escalation. These chances are comparatively less in scleral fixated as compared to iris fixated IOLs. So with all these advantages and the technique, I suggest that scleral fixated IOLs is a safe and better technique to opt for, and it also gives long-term stability to the IOL.
Thank you very much, Dr. Sonal.
So, and my regards to Dr. Vasavra sir, under whom I have done my training, and thank you AIOC once again.
Thank you very much. Tejas, are you ready? Okay. So, please.
So now we have Dr. Tejas Shah from Ahmedabad, and he's a high-volume phaco-refractive surgeon. And thank you, Tejas, for consenting to be the debater at the last moment. And he'll be talking in support of anterior chamber lenses for management of aphakia.
So, good afternoon, friends. I will start with an analogy. What do you do when a speaker doesn't turn up on time? Well, you call Dr. Tejas Risha. Very simple solution, correct? Similarly, when you are left with no capsule or no bag, what do? You call Dr. Tejas Disha. Simple solution, correct? And when you are left with no bag and no capsule, what will Dr. Tejas Disha do? He will implant an ACIOL. So simple, correct? Well, why did we start with ACIOL? When we started doing our FACO with Dr. Vasavda, we didn't have any choice. It was only an ACIOL or ACIOL. And mind you, we had a case probably every day, every week or every 15 days where there was no bag. And what was the solution? We implanted an ACIOL. Correct? Again, a simple solution. And all these patients, after 30 years, when they come back to us, they are pristine. They are absolutely pristine. We have not done a DSEC or a DMAC or anything in any of these ACIOL patients. Yes, the caveat is we do a good vitrectomy, we leave a deep chamber, we do a peripheral iridectomy. And these patients are probably still doing very good. And that's the reason I always choose an ACIOL till today. So that my competitors after 30 years when they will see again a pristine cornea. Thank you. That is what I could prepare in this 5 minutes.
No, I support this. I have few patients, even 25 years of ACIOL.
I think I would partly agree with you, Tejas. In my own time, when there was nothing else available, I did do ACIOLs. One caveat for everybody who's doing ACIOL is please do your white to white. You'll be a lot safer. You'll be a lot safer. Ciliary tenderness, recurrent inflammations will go down.
Kamal,
Do your
उस
white to
time में
white.
तो white to white was like jargon. क्या था वो? There was nothing like white to white. There were only 2 sizes available.
One thing, most of it did
We have both of the debaters here, and Dr. S.P.S. Grewal, the chair. I would request put in some words.
I have used the AC lenses quite a bit.
You're my age.
And with good results. So you see, it all also depends upon how you are trained, what you are trained into it, and it's good to have everything in your armamentarium. There will be situations where you will feel that some A, B, C fits into it. So it should not be a compartmentalized that I'll only do this. So it has to be tailor-made and customized to each patient.
So you want to make a point?
Also, what happens is that if you want to deal with the situation on table, ACIOL becomes the best choice because you don't have to make big sclerostomies and flaps and everything. If the patient is under topical, you just slide a ACIOL and probably take one suture if your incision is leaking, and that makes it at the end of the surgery, and that is what makes it very easy for me.
I know ACIL, putting an ACIL is easier technique and it is also less time consuming. It can be done on that same sitting. But later on, in long-term stability and long-term complications, if we look at, I think we should go for SFIs because the position of the IOL is almost anatomically safe. Other than putting anywhere in either in the iris or in the AC, I don't think it is the best option.
Only the suture life, Gore-Tex.
No. Is the haptic in anatomical position? No.
I think I will just say one point. I agree 100% with Dr. Tejas. When you have no choice, you put ACIOL. But if you have choice, you put SFIOL.
So I'd like to invite Dr. Praveen for their quick comments from the retina perspective, because at the end of the day, we as cataract surgeons would fit in whatever suits us. But what do you feel once you see these patients, the risk of detachments, CSRs, CMEs, and uveitic chaffing of the iris? So at the end of the day, what is your take for this?
No, I think SFIOL is definitely very anatomical, very much in place, very physiological. And it is not that you have to pack or close the case and then send it somewhere else. These days, most of the good centers have a retina surgeon also back up. A good vitrectomy is actually the most important thing for any secondary IOL. Once you have done that, SFIOL is a physiological way to go. And more surgeons, not even retina surgeons, these days a lot of interior segment surgeons are doing a very good job, and SFIOLs is a done thing.
Do retina surgeons have any objection to posteriorly fixated iris IOL?
So dislocation rates are definitely higher. If you do vitrectomy, the chances of any decentration and all that is less, but CME is going to be there because iris chaffing is there. So those long-term issues can happen.
Play devil's advocate, I've seen fewer complications in those who have a nicely done quadriflex IOL than in those who have had a scleral fix.
I think the queen is vitrectomy.
That's for every person.
Yeah. So I think a
A
thorough
good
vitrectomy
vitrectomy
is the
then
most important.
Most important.
Yes, and ensuring that you don't leave behind strands or vitreous petraction ke liye. And so, I mean, vitreous say retina traction or whatever CMEs and
That is the bottom line.
yeah. And then the lenses are secondary.
So a quick last question: what is the take of the house on that reverse enclavation of these AC IOLs? I think of late I've been doing them for all my. So any quick comment from anybody who wants to comment and using
Then the rate of
reverse
distribution will
enclavation?
be more.
Dr. Kiranjit has come with a 4 fixation now instead of 2, and it was shown in the. Yeah. So is the retrofixation for 4 points. It takes care of the coloboma or if the iris is too wide. So that can be also fixed with that one.
But now Dr. Kiranjit has come with a 6-prong fixation.
4
point.
4-point fixation. That I shown in 2 minutes to video. He was not there, but it's like shown his video for that.
So now we are on the way back, and we are on the last debate. And this debate is managing post-cataract refractive surprises. So we all know that we, as cataract surgeons, almost daily face this surprises. So we have Dr. Kamal Kapoor, and he'll be talking in favor of IOL exchange or an add-on lens. So all to you, Kamal. And Vardhman, you've thrown Vardhman off the cruise, I believe. I can't see him. I can't locate him. Huh? Poor chap.
Maybe you got intimidated.
He disclaims any knowledge of what happened to
What happened? Yes. हाथ को वही वर्धमान को फेंकने के चक्कर में
नहीं वो दो साइड के बीच में होगी सार्स साइड एंड दूसरी साइड की सेंटर फॉर साइड दोनों में लड़ाई
पर बाएं हाथ का खेल है वो तुम्हारे लिए है ना
सर अब क्या बुलवाओगे यहाँ पे आप
टूटा बायां हाथ है
ना Okay, so I guess what I'll do is I'll speak for my opponent also, because I'll be sailing in 2 boats.
First, start with for yourself.
See, because I feel the debate actually is beautiful topics, and they've been made to be very interesting and informative. But let's face it, all the speakers have done beautiful justice to what they were saying pertaining to that. You cannot call a Maserati a bad car because of a bad driver. So if in case you are not able to do a procedure or you're not being trained to it or exposed to that, please do not take it off as bad. The carry-home message of this session should be that each patient, each situation, and each surgeon can deliver the best or the worst results with the same thing. So let's keep that in the back of our minds now. So first of all, there's no opponent here. I'd actually decided there's going to be a friendly match, no punches, because Dr. Kiki and Dr. Mani are always telling me कि तू debate में आता है तो तू बहुत ruthless हो जाता है. So I've toned it down this time. So ancient wisdom. Never ever, any surgical field, you see, even when you actually went for your basic surgery posting, my senior resident told me that don't waste any tissue if you can avoid. So when you're burning tissue for a refractive surprise, and when you have an option, you can do without it. So when we cut the cornea or ablate the cornea, are we cutting something which we can preserve is the basic question. This I'll put to everybody. I'll just run through this very fast. Cornea leaves untouched. With the LASIK, you touch the cornea, you ablate, you change the corneal abrasions, you change the biomechanics. I'm not talking about LASIK as LASIK. I'm talking about LASIK now as a treatment for IOL surprise.
If you say it rather vehemently, people will tell you to stop doing LASIK.
That's why I said. And never forget, most of these patients who are having an IOL surprise are elderly patients. The biomechanics are already different. Nomograms are different. They have dry eyes. So keep those things in the back of your mind when you're planning bioptics for these patients. And the regression formulas, and don't forget, the equipment you require. and accessibility to a LASIK machine. So if you're a cataract surgeon and you're not much into refractive and you have an IOL surprise, you need an access to a refractive machine, which probably costs a lot. So, you're cutting the cornea, changing the... Another thing is altering the IOP values for future by changing the corneal curvature. Are you able to take care of your excessive high levels of myopia or high levels of hyperopia or dysphotopsia or even presbyopia while you're treating a LASIK for an IOL surprise? But yes, with an IOL exchange or an add-on or a piggyback lens, you can take care of all of them without resorting to an expensive machine. What if the patient already has a dry eye syndrome? Are you left with an option of doing LASIK? Okay, you can say, okay, dry eye, maybe I'll go for a PRK. But PRK also does induce dryness. So maybe most of us have a mental block because we feel in our mind that doing another intraocular surgery, well, this could be just a mental block, so we could open our minds to that. So what do? I have walked the talk. I have, for a long time, for low moderate powers, I only probably resort to a bioptics or a LASIK. 2.5 is my cutoff point, and only myopias. Hyperopias, I go for an add-on lens, a piggyback, or if it's another issue, dysphotopsia or something, I might go for an add-on or a removal of lens, depending situation to situation. Now, what are you doing? You're making the keratometry flatter, potentially more dry eye. Do you want to shift to PRK? Yes, again, dry eye. Residual bed thickness is an issue. What if the patient has a thinner cornea already? Do you have an option? You don't have an option. You have to go for a piggyback lens. Chances of having ectasia at a later date. Dry eye is a huge issue in this patient age group. I'm sure, raise your hands. How many of you do a simple normal cataract and patient for 2 months is saying, "Aankh mein kuch ragad raha hai"? All of us. They already have dry eyes. And once you do LASIK on them, you're exaggerating their problem. The advantage is no dependency for any machine. You just need to correct the refraction. There's an Excel sheet which I have for myself. People want, they can contact me. I give them an Excel sheet, put the value, what is the residual power, you get the IOL power you need to put. Spherical equivalent, bang on 6.6, day in, day out. So me and Dr. Uday Devgan has worked on this nomogram and developed it. So higher powers, I would say lower powers, you can go for LASIK. You can go for LASIK for lower powers, 2.25. Higher powers, don't go for LASIK, go for an IOL exchange, especially if it's hypermetropic. And a lot of times you can have hypermetropic surprises. There's no way LASIK is going to help you there. Add-on complications, yes, you could have a bad power again, but hello, you can do a touch-up. Suppose you wanted to correct -7 and you just landed up with a 0.5 here and there. Patient still angry, you can do a LASIK, 0.5 diopters. But you can't possibly take -8 or -9. It's a reversible procedure. Now, I'll show you some interesting procedures just to take care of the mental block. No need, a lot of times you think it's a messy situation taking out an IOL. This patient has an IOL, I'm just going to go a little faster, put in viscoelastic, coat the endothelium properly, just use a 5.25 millimeter, go approximately 3/4 of the blade, go in, pull the lens out, clean, smooth, one suture in the center. If your wound construction is fine, the procedure actually is over in 3.5 minutes. Neat and clean, no bleeding, everything is stable. This patient wanted a multifocal on second thoughts. I just took it out, put it a multifocal. So you might say, making a 4.7 millimeter incision and putting a multifocal astigmatism, you make a beautiful clean cut wound with a keratome. You do not have astigmatism. Another video, same situation, big, huge IOL surprise. This time I decided to come through a smaller incision, which would not require sutures. Again, see, neat and clean. We'll just jump the video, I'll go fast, pull the lens out. This one probably needs, I broke the lens while pulling out because the incision is very small, but eventually it does come out. This one is approximately 3.5, 3.75. That's why you see there was so much of stretch. The lens folds, but you need to coat the endothelium properly. I would not recommend this for everybody. I was just trying to do that I might not need to do suturing. So the suturing is done, no need for suturing, wound hydrated, patient is doing fantastic. Now coming to an interesting situation. What if you operated a patient many years ago and now he wants presbyopia? Can you do LASIK? You can't. You put in a piggyback presbyopic IPCL. This is my OT technician. I operated him 20 years ago and now he's able to give me a bent cystotome without glasses and I need to go under the microscope. This he does without glasses. Okay, now this is... this is another case. I'm jumping videos.
Just last 1 minute.
Minus 4.5 correction, add-on lens, trifocal. This patient also wanted a trifocal, was operated for monofocal. I put in a top-up trifocal on top of that. This patient also had a residual minus 4.5. So I corrected minus 4.5, also gave him presbyopic correction. Can my LASIK do that? This is add-on. Add-on try.
Kamal, why don't you incise the lens and
Sir, I
come
used
out
to
through?
do that. I used to do that, and I've got many bloody videos also of that. You know, the PC cutting, sometimes the iris getting sharp.
If you have this good holding
I
instrument
have,
and
sir.
good
I have. Trust me, I have.
I
This-
also have.
Sir,
I've
because-
done a lot. I mean, it works well.
So
It works
this is magic. Everybody in my team has stopped cutting the lenses now.
well. No. I wouldn't agree.
So I'm sure when we come here for the debate, we all agree to disagree. So this is again -6. Would you correct -6 with the LASIK? Flat cornea. So this is what you can do. You can actually put a piggyback. I've got a very interesting case coming up. These lenses are not your regular lenses. I designed these lenses. This is a 13.5mm lens with a non-square edge. It's a hydrophilic. Another trick, if you want to piggyback, never put the same material. If you have a hydrophobic, don't put an hydrophobic. If you have a hydrophilic, put an hydrophobic. Change the material. The chances of intralenticular membrane are 0 if you use two different materials.
So what is the difference in your design of this lens?
So the lens is larger, it's 13.5, 0.5mm larger, and the edges are not square, they're round edges. Because the square edge will eat into the zonules over time.
Okay.
So they are very stable. Everything is same, just the diameter is this large. They are available, they can be made on order for you by Care Group. And this is another interesting case. This is not similar. This lady came to me saying a refraction keep changes. So I saw that the lens was a tripod lens put on a PCR. The lens would come into the anterior chamber and the posterior chamber. I could have explanted the lens. So what did I do? I got a 0 power same lens which I got designed. I did vitrectomy behind the lens, put in a new lens on top of it. The lens is back in its place.
Cornea based.
-17. Would you correct it with
Cornea
LASIK?
based correction.
-17. Case operated by me nearly 16, 17 years ago, traumatic cataract.
So
you can't remove the lens. There's complete fibrosis.
Kamal, you need to summarize now.
Thank you. So I guess special cases, lower powers, you can go ahead with LASIK. It's absolutely safe. But higher powers, please do your pre-op properly. Corneal surface disorders, corneal biomechanics, thin corneas, and then you can go for. Otherwise, I would go for an IOL implant or an explant. Same, sir. जो आपका सेम होता है, जो आपका पावर पहले डाला है आपने. Normally इसीलिए मैं add-on lens डाल रहा हूँ, explant नहीं करता हूँ. मुझे new power पता नहीं है, तो मैं add-on कर देता हूँ. Minus या plus. Explantation has really gone down, sir.
So I think Kamal has nicely summarized. I just wanted to add 2-3 points here. For me, the touch-up would be much easier when I do a cornea-based, because any kind of fine refractive error, if I do a premium IOL or maybe a monofocal IOL, so maybe low diopters,
Absolutely.
I think they're absolutely wonderful on the cornea, because I don't
And give
want
it to you.
those errors.
Granted.
And so all these multifocal where I have, surprises 0.75, minus 0.75.
Absolutely.
So then would you do a surface procedure or a LASIK?
LASIK, because surface healing is delayed, and then dry issues, and the patient is not comfortable, because at the end of the day, these are all premium patients. They don't want those 4-5 days of unease and pain.
And sir, surface procedure sometimes does cause haze in few patients, and you can't predict when.
Low power, 0.75.
Sir, kabhi patient ki
So
predisposition
I think
bhi hai.
Arun must have had an experience. I think Trans PRK works very well in the Shrink
Yeah.
platform. So, but
But
I
4 days of
personally-
pain for the patient.
Yeah. So I personally would do on a LASIK.
Thank you, Sonu. Thank you.
So
Good. I think you put forward the other option very well, that you need to keep both the options open. But you also need to be more open to explants.
I think my idea is IOL exchange is the last choice. I think IOL exchange is the last choice. If the patient is myopic, you can go for LASIK, you can go for add-on lens. If the patient is hypermetropic, then don't go for LASIK, go for add-on. This is the best choice. And if somehow you have to explant the lens, be very careful. Try to take it out. If the lens haptics, you found the haptics are fixed, you can just leave the haptics, cut it, and take out the optics part only. But that is the last choice, because you're not very sure, you will not get a surprise again. after putting the second lens also. So I think these two LASIK and add-on lenses are quite effective. Their prediction is very, very high.
Yeah, the situations will vary. Sometimes, you get the wrong lens on the table and you put the wrong lens. That means at that moment, psychologically, it is best to tell them, okay, we'll put the other lens.
So I think let's have the chair, Dr. S.P.S. Grewal and Dr. A.K. Grover, sir, to be here and put into words, sir. And we'll have a panel, the entire panel coming with us, and a group photograph of the entire the cruise.
Thank you so much, Dr. Sono. It's been a wonderful experience to be on the cruise, and very well debated subjects. Everybody tried to win the point, and I think everybody did that. Thank you so much. Thank you so much for a wonderful
Some
program.
were more successful than others. But I think everybody won. The audience was the first winner. They voted beautifully. And the organizers were wonderful. The speakers come last.
So can we have the honored panel with
And
us?
0 for chairpersons.
Panel and the speakers, please. Can we have a photograph? Harshul, please. Shell, come. Anurag, Rajesh, Tejas. Rohini, can you do me a favor?
पीछे नहीं है नहीं है मुझे नहीं भाई देना
Thank you. So can you all join in for a group photograph? Let's make it a big group. आ जाएंगे ना आ जाएंगे यार. Last time please join in. We can have a group photograph. Yes. You want to action Femto and Feco both? Action.